Hey, welcome back to another episode of Raise the Bar. I'm John Krewson.
I'm James Nippert.
Today we're talking to Dr. Tom Maddox, cardiologist,
Academic,
technologist,
healer,
philosopher.
philanthropist? Maybe.
Enjoy.
Yeah, so you are fully Innovation Lab.
So I'm now 100% in the 90% in the innovation lab, 10% practice.
And you still practice how? Wasn't it like every 6
Where am I now?
weeks?
I think I'm like 6 weeks a year.
Okay.
Yeah, so a week or 2 weeks, and I'll go round on our inpatient service. So just hospital-based practice. If you come into the hospital with a cardiac issue, either you go to our primary service, and we'll be sort of the main attending, the attending of record, and manage your cardiac condition and pull in other specialists as we need. Or if you come in, let's say you come in, you broke your leg, and you go into the ortho service to get it fixed, and you have AFib, and the AFib crops up. Ortho would say, hey, we need cardiac consult, so I would go help them. So
And
I
this
do
is
those.
in a planned or unplanned work scenario, or it doesn't matter?
Interesting. So the two services there's a mix,
Okay.
which sometimes makes the cognitive switching of our work difficult.
Yeah.
The first one, where we have our primary service, that is planned work. I know every morning I'm going to come in and round on you.
Okay.
And we've got the plan. We're the main architects and administrators of that plan. And so we come in and like, how are things going? Like, you came in with too much fluid on your body. We're going to give you medicines to try and get that off. Takes roughly a day to see the impact. So I've come back the next day. How's it going? Do you feel better? Do we need to make any changes? That's all planned.
Okay.
If in the middle of the night you happen to develop an arrhythmia that out of the true we need to treat generally fairly quickly, then that's unplanned. And so we have like an overnight team that's on call. They're not doing any of our planned work, but
Okay.
they are available
Yeah.
in case something untoward happens.
Interesting, because you're still talking about planned versus unplanned within the scope of who you've decided to treat inside the walls of that unit, that hospital.
Mm-hmm.
But there's another uber unplanned or hyper unplanned
Mhm.
aspect that sounds like is just completely walled off from that, which is your ER.
Yes.
So if
Yeah.
if someone comes to the ER, and this whole conversation, by the way, is this is going to be what it looks like when someone whose entire medical vocabulary was taught by Grey's Anatomy
Oh, good. That's a good
interacts
one.
with someone.
That's a good one. Yeah.
Yeah. So I'm sure.
But you're of the age where maybe you got trained by ER as well.
ER as well.
Yeah,
Absolutely.
okay.
Yeah.
So I was all Scrubs.
Okay.
Yeah, Scrubs.
Which
So
I've heard Scrubs is the most medically accurate.
No,
hospital
ER.
show.
No, ER was like the banner for that one. They
Really?
got started.
oh, good. Okay.
And where's
so,
House on the spectrum?
House is
Why is everything lupus?
House is good in terms of like getting into the illnesses, but it's completely ridiculous.
You don't.
In
You don't
terms of
break.
how they manage.
You
them.
don't break into
Like, I'm
patients'
doing-
houses.
I'm figuring out your chemo, and then I'm opening up your brain. Like, what? And there's that team, I'm like, you're doing what now? So, and then I'm delivering a baby, and I'm just like, what?
Okay.
Do you have anybody else in the hospital? Like, but a lot of their diagnostic stuff was pretty decent.
Okay.
And with ER, so I'm of the age where ER was
Yeah.
there, and I was actually, remember Noah Wiley, that
Mhm.
actor? So he was a medical student in the show that became a trainee.
Yeah.
He was my class. So when he was a third year med student, we were third year med students.
Okay.
And in some ways, this was back when you had prestige viewing, right? You'd go on Thursday night, watch
Yes,
it.
That's right.
And the next day, you literally could quote something from the show on rounds, and it would be right.
Wow.
And it turns out that they had the medical advisors they had were, docs and teachers, and they really thought about that deeply.
That's cool. Well, now I want to go back and watch ER again. I loved that show.
Yeah, that was a lot of
Clooney?
fun.
What?
Clooney, yep.
Clooney, oh yeah. Clooney,
He's
Maura Tierney,
probably
Eric LaSalle.
Eric LaSalle. Juliana Margulis. She's
That's
probably
right.
another breakout from that show.
That's
Probably
right.
Clooney and
Yeah.
Margulis
Yeah.
were the two that made it out.
Mm-hmm. Okay, so an ER term, patient presents with atrial fibrillation, heart and tachycardia.
Yep.
Heart's beating 150 a minute.
Yep.
Comes to the ER.
Mm-hmm.
You have, in your world, no, that doesn't concern you at all. Not as a human being, I'm sure it would, but
Do I know what to do?
no, in your world that you live in day in and day out, do you even know that that's happening?
No, it's you can imagine it's this huge machine, right? So the vast majority of people who come to the hospital come in through the ED. I'll make it up a little bit. Let's say 80%.
And
With
it's emergency
20%,
department.
yes,
Okay.
with 20% coming in for a planned procedure.
Yeah.
Like my buddy just got his hip replaced. They knew that,
Yeah.
so he went and checked into the hospital, often the day of the procedure, and then stayed a night. Sometimes you don't even stay a night anymore. So there's an element of planned elective care that our hospitals manage,
Okay.
and actually more and more of that's getting pushed out into the so-called ambulatory world. Like ambulatory surgical centers are a thing.
What does that mean?
Ambulatory means you're walking.
Okay.
If you're ambulatory, you're walking. So the idea is if you walk into a
Ambulating.
clinic, walk into a surgery center, these are ambulatory sites of care. And we're finding that it is better and better to separate where elective care is occurring and all the planned work and more emergent care and
Why?
critical work.
Due to infection or?
Yeah, I think it's a good question. Like infection, some of it, not surprisingly, is driven by differential reimbursement rates. You can get a better cost structure in an ambulatory center. So if you're getting paid the same rate, your margin's better.
Okay.
So there's a little bit of business to it as well.
Okay.
But I think in some ways, like managing a car wreck and the orthopedic injuries that would result from that, and managing an elective hip, which is like a nothing procedure now. It's a big deal to the person.
Yeah.
And if we all get it, like it'll be a big deal to us.
Yeah.
But it is so routine, and it's just such a
Routine.
It's a
Very
different,
straightforward
It's a different speed.
and it's very safe now. I mean, the reason you can do it away from the hospital, it used to be that it was risky, that like a reasonable percentage of people would have a big bleed or maybe have an infection, or just it would be a real production,
Yeah.
particularly if there was a complication. Now it's so low that we can do it safely for almost everybody in an ambulatory center. And if something crops up, obviously we can get you to a hospital and manage it.
Okay.
But that's where we're headed.
Interesting. So just to close that out,
Mm-hmm.
if what is the root, the ambulatory root word? Ambulate?
Ambulate. Ambulate
To-
is to walk.
to walk. Then why are 100% of the people that take a ride in an ambulance not walking?
That's a great one.
I mean, there's got to be a reason for that, though, right? Like,
Yeah.
Is it a
It's possible at one point the ambulance was carried to you or walked to you. If it was a cart
I don't
or
know.
yeah?
That's a good
that has
question.
always confused me because I look to ambulance to help me define all these other. I see whatever in other areas, and I'm like these are not. matching
You're
up.
gonna get a super geeky email from me like later tonight
Okay,
after I
good.
research that.
Well, just to be when I first heard ambulatory surgical center,
Mhm.
I was picturing like an Autobot that would walk to me.
Oh,
And for like
Yeah.
And I was
Well,
picturing
maybe
it was a
one
mobile.
day.
Yeah.
where instead of Walmart getting the 18-wheeler unloading inventory, it's a place where we're just unloading people from ambulances.
Yeah.
And that's the kind of the opposite of this.
The ambulatory surgery center? Yeah. Now the ambulances, for whatever reason, the word being that, is for emergent care.
Okay.
And we actually call that emergent transportation, just like our helicopters, fixed-wing aircraft,
Yeah.
and ground-based ambulances. Those are transporting the emergent stuff.
I don't mean to make this an episode about etymology, but emergent and emergency also feel like two
different
a
things.
word where the root became its opposite. Where something that is emergent, at least in the world of complexity science, where something
Yeah.
displays properties when self-organized, that where those properties don't exist as
Yeah.
individual units.
Correct. Yeah, it doesn't quite have that meaning.
Yeah. So how did we get to emergency?
But some sort of an urgent, like we have urgent
Yeah.
care, emergent care. Yeah.
Oh, okay.
There's emergency care, there's urgent care. I'm not going to make the terms total right. There's one more level down, and then there's ambulatory care. Convenient care, that's what it is.
Mm.
So there's emergency, urgent, convenient, ambulatory.
So, okay, good. Etymology aside, those 4 categories, I wonder if there's a lesson for us in the world of technology where that, and maybe some larger organizations are already applying this concept that, like there's a different world for feature development than there is for feature maintenance once it's in production. The prevailing
It sounds a
theory,
lot like Knebben.
maybe. But what we have to reconcile with is in our world, and of course, we're not dealing with life and death. So, and we're not dealing with tangible goods. We're dealing with virtual goods, so we can throw it away and start over very cheaply. But in our world, the separation of that planned work, convenient work, and the super urgent work, unplanned work. Current theory is all surrounding mush it all together. Make these people over here who are building this thing responsible for the maintenance of it, so that you don't end up with a situation where this group is creating a maintenance nightmare for this group.
Right.
How do you
Plus,
reconcile
maintaining it, you have the beauty of the institutional knowledge of how it's
Exactly.
built, right?
And the
Source code.
instantaneous feedback loop of if something keeps breaking, you need to.
Yeah, I drank that Kool-Aid and still think it tastes good. So,
Okay.
but it's worth debating, right? Like, there's pros and cons to that.
Yeah. Well, there's also, we're talking about different things fundamentally. We're talking about the human body versus this virtual.
Well, but I'll push back a little bit, because the more that, I'll say this like it's you and me, like it's a separation. It's not, because I'm in technology as well.
Yeah.
The more that technology becomes part of healthcare, the more you jump on our boat of like, this matters, potentially in a life and death situation.
Yeah.
If the EHR goes out, things are, now you're kind of foobar for a little while.
Yeah.
Right? Because like everything I know, right.
EHR is electronic health record.
The electronic health record. So, we are very dependent on the information in that. In fact, we've now, like we've done with a lot of our digital tools, offloaded a huge amount of our knowledge out of our brain into the EHR.
Yeah.
And there's a little bit of automation bias that's cropping up, like we're always concerned about with AI, that if I just I'm not going to memorize anything about you because it's all there in the EHR, which is a very rational thing to do. It's just like you don't memorize your wife's phone number anymore because it's in your phone until your phone runs out of power.
Yeah.
And you can't,
you don't know how to get anywhere.
How do I get anywhere?
Yeah.
And there's a little bit of that going on in medicine, and frankly in all our industries. But speaking specifically to medicine, that means if it goes out, there are enormous redundancies and backup plans. And you can talk to Jerry, and it's like, what happens if Epic goes down?
Yeah.
There's a whole thing that kicks in where we have an offline instance. There are things on the desktops right now, if it's the main thing out. Or we can even we have a paper contingency plan while things are down.
It's interesting. Saturday Night Live does not use automated teleprompters or electronic teleprompters.
Oh, they just do the cue card
They
thing?
still stick with the cue cards 50 years later because cue cards cannot go down. So that's not their contingency. That is plan A for them.
Interesting.
I'm wondering.
But you're also probably improv helps a little with that, because you're not having to read a script.
They are. They do. They read every word. They would.
Really?
Performers on the show get held accountable when they
deviate
the script. Yeah.
Oh, interesting.
Yeah, but they are. So there's a situation where by 11:30 at night, when they realize they thought they were they're about 5 minutes behind, 2 minutes behind, 45 seconds behind, they're going to take one of those cue cards.
Oh, edit it.
But even to so I watch SNL much more casually than I come in and out. It seems like that reliance on the cue cards has gotten worse compared to 10 or 15 years ago, where when I check and when I see the viral skits or whatever, I see people just staring directly at it and reading whatever is on, and there's no more acting.
Yes.
The guests are worse than the cast, for
this
sure.
goes back to the 90s. There's a story about Janine Garofalo getting it handed to her by Al Franken because she's trying to look at her scene partner as opposed to looking over here at the cue card. And You know, like I think the quote in the book is like, just read the fucking cue card, Janine.
Huh.
Yeah, like they want you to rely on that thing.
Huh.
Which to me as the viewer makes for a less interesting experience.
Yeah. So I mean, translating that back to either the world of technology or the medical world,
Right.
Plan A as that least automated, the least technologically advanced. Where is that the opportunity to learn from that?
In medicine and technology, like, say more.
In technology, I can tell you there's a groundswell of interest in getting away from, say, Jira and getting back to plans on paper that can be modified more easily. There's a lot of talk about...
See people coming back into the office more.
What's that?
More in-person communication versus reliance on Teams and hope you read my email.
Yeah.
Because they're finding the tools are just not helpful, or what problem are they trying to?
Yeah, it's not that they're not finding the tools helpful, it's that they're creating rigidity where they were hoping those tools would have created flexibility.
Interesting.
Yeah.
Okay.
But then there's I can't remember the word.
So it's less about the digitization of it, and it's more about just what's my interaction with it.
Yeah. But also when you layer on top, there's these ideas that the notion that if you write it down, you're more likely to remember it.
Yep.
And the idea that when you write something that is hard to read, that the person reading it that's hard to read remembers it more than if it was a neatly typed font.
Yep.
All of those things sort of play into this idea of maybe we've over-relied on the electronic version of
yeah, so I think there are two phenomena that are interesting that I think of when you talk about that. One is, and we had our designers do some shadowing of our docs on rounds, and I always love like listening to the interplay, because I'm an old dude, right? And so it's fun to watch the digital natives. Our trainees are late 20s, early 30s. Our designers are roughly that age. Mm-hmm. And watching them interact. Now, the docs, they're technically savvy from a casual point of view, but they're not deep designers or anything. Our designers are deep in design, but don't know anything about medicine. And so they're learning from each other. And what's interesting is our house staff, and I see them do this to the day, they do everything in paper. We're very Epic-based, but we do it in paper. And we actually do everybody's done this. Like you talk to any doctor, like, oh yeah. You make little check boxes and you write down in your chicken scratch, like, what do I have to do today?
Yeah.
Everybody does it.
Yeah.
And I remember designers were like, why don't you digitize that?
Yeah.
And I think right now it's basically an interface issue. People are like, it is too clunky to get on Haiku in our case, or whatever the digital interface is to our EHR. And to your point, and it's like immediately, I can do it very quickly. I can do it as much faster than I could type, and I remember it better.
Yeah.
And it's partly that just the mechanical act of writing that helps.
Is that
I would hope that some of that does not go away, even if they find that quicker way to...
But what if, like, I'm running out of time, I'm really busy, I've got 3 things left on my to-do list, but it's like, and we know this is why digital is helpful, like it is locked on your paper. What if you lose your paper? Like all the stuff that's like the problem with analog remains, but it's largely an interface issue. Now, the second thing, which is somewhat connected to this, is we've just finished a pilot that was like mediocre in success, but it's promising where I think it's going to go, of using generative AI to listen to a clinical encounter and then start recording the information.
Okay.
And I think this may be the path towards the interface solution.
Yeah.
It won't necessarily help with the whole cognitive sort of cementing that occurs with writing. So maybe there is value in having something like that continue. But what we found is, so the way the pilot works is you and I are in, you're like, hey, doc, I'm coming in for a cough or whatever. We're audio recording the entire thing with your permission. And then once we're done, we ship it off to the GPT. It generates the note in the format that we typically write our notes. And then it presents it to me and I edit it for any changes and then I sign it and it's part of the record. It like did okay because partly what we talk about, how I examine you, I don't typically verbalize that. Like if I'm listening to your lungs, I tend to just listen.
Yeah.
Maybe I'll say, hey, it sounds okay. But
Sounds good. Yeah.
yeah, but it's not going to like, the audio isn't hearing enough to be able to then generate what I would normally write.
Yeah. So you have to learn how to sort of narrate what you're hearing. And
well, actually, what we're doing is teaching the tool that when I say it's okay, it translates into
This is
medical
what that
speak.
actually means.
Okay.
This means lungs clear, no RALs, crackles,
Yeah.
you know, the other things we kind of say from a medical point of view.
Yeah.
So there are ways to overcome that. But here's the thing. The clinicians are like, it's kind of early. Some of the stuff sucked. Some of it didn't. Patients, almost all of them were like, that was amazing. I have not had a clinic visit in years where a clinician wasn't glued to their screen.
Yeah. Just
You actually talked to me. You heard me.
Mhm.
And this is one of the more personable clinical encounters I've had in years.
I'd prefer that as the measuring stick over.
So I've had the same experience so many times. It's led me to the point where like I don't think GPs need to exist at this point because how little value I get out of them. Every time I go to a GP, I can't tell the difference between a GP and a nurse practitioner.
Mm-hmm.
And when I go to my GP, half the time they're not there, so I get the nurse practitioner, and they're all there for prescription vending machines, and they're glued to their screen the entire time. Anything that's grander than something they can look at, they refer me to a specialist anyway.
Yeah.
And yeah, I can't even remember the name of my last couple GPs.
Yeah.
Because it's been such an impersonal
It's
encounter.
impersonal. You also, with all due respect to GPs, you're probably not getting what a really good GP is like. Because they would, and this is just hard in sort of our current reimbursement structure where you're paid to just like churn through people. And it generates a system that delivers exactly what you're talking
My
about.
appointment's at 8. I get there. I sit in the room for 45 minutes. I spend 35 seconds with the doctor. And
our burnout rates are legion among our GPs
Mhm.
accordingly. In the ideal world, what people go into primary care for is for the relationship for years.
Yeah.
And actually what it should be is sitting down and going, James, you feel fine. Great. That's great. Let's talk about your life. Like, you've got a young kid. How's the stress level? How are things going with your wife? Are you talking about things? How's your mental health? What's your workload like? Are you doing the things that we know can promote long-term health? And now I'm starting to build a profile for you that helps me understand that inevitably when something emergent crops up, I'm going to have all that context to best address it with you. You're going to feel connected. You're like, Maddox knows me.
Yeah.
And I'm going to go to this guy. And so I think somehow we need to get back to facilitating that kind of long-term relationship that allows you, and I don't know if we can pull it into an analogy for technology, but I've known you from the beginning. So when things are a problem, I know best how to handle it.
Yeah.
So I don't know how you do that.
What I heard was service quality. I mean, we talk every single day about service quality, and as our number one priority. This is we're a services-based company. We provide technology services. You can differentiate service quality from technical quality. Technical quality is how good is the code after we wrote it.
Yeah.
How error-free is the feature.
Sure.
Service quality is, did we make you feel important while you were here?
Yeah.
Do we act like your business is important to us? Do we treat you with respect? Do we act like we understand who you are and what your needs are? Do we adapt accordingly? That's, I mean, it's not.
Well, it's the experience and the, I don't know what to call it, like the technical mechanics. It's like the two together, right?
Yeah,
that
right.
you need.
Yeah, but
Like, it
none of
needs to
what you
work.
described had anything to do with how medically
how good the
proficient
medicine was.
that practitioner is.
Yes. So one of the greatest phrases that I've heard from when I was in training, when I was a fellow, there was another fellow who was several years ahead of me, and she had graduated. So now she was in the community as a practicing cardiologist. And I was arguing with her at some point, like in a collegial way, but I was arguing like some medical point, a technical point, essentially. Like, no, you need to be able to treat this way, and people who don't do it this way are not practicing standard of care and whatever. I said, and obviously the most important thing you can be is, a fantastic doctor who knows the latest evidence and is applying it each time. And she said, yeah, of course you think that, because you're still in training. She said, when you get into the real world, I will tell you there are the 3 A's of being a fantastic doctor, and they are in order: affable, accessible, able. And the first 2 are the experience, and the second is the technical, right?
Yeah.
Now, all 3 are important. You don't want, a quack or somebody like practicing crazy.
Yeah.
But frankly, a lot of patients don't really know that, right? And they're going to totally remember if they can get into you, and if you're like a good person, like a nice person, which gets to the bedside manner.
So let's dig in on that. But I want to think through this 3 A's, because I can't think of a scenario, an industry, a profession where those 3 A's don't apply.
Yeah, agreed.
Yeah, I think of the times that we've come in and either been met with resistance because we're consultants, or we're there to clean up another consultancy's mess. And it's almost always, well, they were a revolving door. We never saw the same person twice. They weren't there when we needed them, or they were tough to get along. Going back to affable.
Yeah.
And so it certainly seems that there's carryover, at least in any service-based industry.
All right, stop.
We hope you're enjoying today's conversation, but we need to talk about your cloud migration. How's that going for you? Is it taking too long? Is it costing more than you expected? Way more? Sketch makes migrating to the cloud easy. Our cloud optimization team can find out what's going wrong with your migration, fix it, and even pair with your team to upskill their understanding of the cloud environment. Now that's raising the bar. Reach out to Sketch today and find out how they can help you save time and money with your cloud migration. Now back to the bar.
I've been working on this belief that if lay people could learn the fundamentals of Bedside Manor, or I guess I've had this belief that Bedside Manor is a teachable thing, that it's that medical school recognizes it as a component of how to do your job. I went so far as to ask some other doctors that I know if they have taken a course like that, and if so, do you have to enroll in medical school in order to take it?
Right.
But you mentioned that there is such a class.
Yeah, I don't know that it's called Bedside Manor per se, but I think ours was called Patient Doctor or something like that. And I think most trainees would say, yeah, I remember some class that was roughly along that. How do you sort of interview a patient? How do you relate to a patient? And again, it feels a little bit like, I went to kindergarten. I know you're supposed to do that. But, when you actually sort of get serious and talk to people who teach it, there are a lot of things. It's basically the concepts of emotional intelligence, right? And I think a lot of industries are starting to realize, this actually matters because fundamentally we're all humans and we interact in a human way. And if you don't do it, or you neglect it, or you ignore it, things are going to go south in some way. So Bedside Manor is that manifestation, I think, in medicine.
I would imagine the doctor who ignored it or blew it off in training, once presented with the realization that I'm the one who has to break this news to this patient, that something terrible is going on inside their body. At that point, they're like, man, I should have paid more attention.
I wish that were true, but it's not. Because we get, because medicine enjoys the place they have in our social strata, like we're elevated, right? And there's such an information asymmetry. There's such a reverence. It's less so than it used to be, but there's still the doctor, they know best, et cetera. Particularly if you're scared and sick, you're like, why would I ever question you're deciding what chemo you're going to give me? My God, just fix me. You're in that mindset, so you're not going to be pushing back or anything like that. I think it allows for a lot of, frankly, bad behavior. Not intentional. There's a few rare total assholes, but even people who just are not that considerate or that attuned to the importance of the human interaction, they can get away with it a lot. And it's sort of a stereotype, but we say this a lot with surgery. Like surgeons tend to be gruff and sort of mechanical, and they're the carpenters or they're the technicians or whatever. And everybody talks about the gruff sort of jackass surgeon. And that's not universally true by any stretch. And the fact of the matter is, Surgery is getting a lot better at it, and I would say it's correlated, frankly, to the increasing prevalence of women who are surgeons, by the way.
Interesting.
But nonetheless, I've certainly seen, and even as recently as in the last several months, I've seen examples where people are not very skilled at that, and they get away with it.
Yeah.
But they could be so much better, and it could be such a better experience for everybody involved. And it's not just a nice to have. If you have that relationship and that trust and that sort of the bonhomie that comes from a nice relationship, it actually matters about how you're going to engage in your care plan. It's going to engage in how much you offer up to that doc about your symptoms, which ultimately may be really important to know for us to direct the best therapy to you. So it has very real health consequences if you can set up the environment that a good bedside manner provides to facilitate really good communication with your patient.
Well, two thoughts I have. One, it seems like the more psychological safety trust you have with the patient, the less likely they are to lie to you. And for some reason, people love lying to their doctor. How many drinks a week you have, or how many smokes a week, or what is your relationship?
There's a satisfying bias, I think is what it's called. Like, you don't want to disappoint.
You want the doctor.
They're your parental figure, right?
Yeah.
You don't want to tell your doc that, like, I don't get off the couch.
Yeah.
Yeah, man, I'm hammering
they're giving
half
you
a bottle of
your-
scotch a week.
That's a thing where you want the doctor to be proud of you. I've observed that many times.
Like,
You
I'm
don't
here to
wanna let them down.
perform. Like,
Yeah.
I'm healthy.
Yeah.
Like, how am I as a patient?
Yeah.
I've had that
Well,
question
so-
directly. Am I a good patient or
Really?
a bad patient?
Wow. Why does it matter?
Am I nagging you too much?
Yeah.
But here's the corollary. I mean, this is the boss-worker relationship.
Oh,
You're
sure.
looking for
There's a
your
power symmetry.
you're looking for your attaboys.
Yeah.
Particularly
Which is
because
why I think that bedside manner education would be so valuable to
Yes.
the boss, because just like the doctor needs to say, "I'm afraid it's malignant,"
Yeah.
that the boss needs to say, "I'm afraid you're not cutting it."
yes,
And there are plenty of bosses out there that fit the description that you gave of the doctors or the surgeons that aren't really all that good at it. And I don't know that the training exists in this world either.
So the class that you described, is it mandatory?
or mine was.
So
Generally,
I wonder if there's a correlation between the people who choose to skip it versus the people who show up and are excited to be there, and like the people who are okay going there, they're probably the ones who need it the least.
100%.
They already value
People who
it.
love it are the psychiatrists. I'm
Yeah.
not kidding.
okay.
The people who hate it are the surgeons. Again, generalizing. But
Yeah.
the stereotypes exist because there's an element of truth on them.
But even there's a business outcome. Aside from all the health outcomes of my patient actually tells me the truth, so I know I can better diagnose them and care for them. But the business outcome is, if I have a bad relationship with my doctor, I'm not going to keep going back to them. If they blow me off, if they're always late, I'm just going to find a different.
Yeah, I mean, I will say that frankly, healthcare is stickier than that. And it's
Okay.
rare that somebody leaves. You're just kind of rooted a little bit because, like, switching costs are high. Insurance plans kind of direct your care anyway. It took forever to get into the freaking clinic, so am I really going to pull out? That's another example of switching costs.
Interesting.
So it's less about the business, I think. But I think if the emphasis can be made, like, this will enable you to deliver better health outcomes, I think that would be motivating to some. And then, frankly, up until recently, there was no feedback and accountability mechanism. And now there is.
What?
Patient surveys. Have you guys had to fill out a survey after a visit?
I get the option to.
Yeah, it's new.
Okay.
It's new. That's only been true in the last 5-10 years. But now the more progressive health systems, for example, I heard Northwestern, like, we get graded and comped based on our patient survey scores. And they're starting to introduce that at WashU and other health systems around the country.
Do you see functional medicine having an impact, like traditional medicine seeing what's going on over there in the functional medicine world? And
What do you mean
saying-
by functional medicine?
It's I've been hearing more about. First of all, it's sort of like the boutique, the
Concierge, sure.
style,
Sure.
but also there's this noise about if you have an acute problem,
hmm
you need a traditional medical practitioner to help get you through that
Yeah.
issue. For more chronic issues,
Yep.
a different system is required.
Yeah.
And I wonder if like these patient surveys
Mm-hmm.
are a result of seeing that like there's an alternative cropping up that
Maybe. I think it's a good question. I'm not sure where the surveys came from. It may have just come from a fairly altruistic goal of saying, like, we need to make sure the experience of healthcare is valued and measured and addressed just as much as the outcomes of care. So however developed, there's now Preskini and PRC and these like enormous measurement companies, which is its own industrial complex. But nonetheless, it's a way to assess the experience. And we've talked now, there's sort of a thing called the triple aim of healthcare, where we're trying to optimize the health of the population, the experience of healthcare, and then the costs of it. And so experience really has become, I think, a lot more prominent and speaks to some of the patient, some of the bedside manner.
Yeah.
The other thing that's been interesting with bedside manner, I didn't learn this until 5 years ago, is that so much of medicine and the outcomes that flow from it is behavioral change of the patient. Yeah. Right? Probably the doctor, but nonetheless the patient. And the way that you spark change in people is a whole different skill set than what we learn in med school. And so particularly those specialists or those areas of medicine that rely a lot on behavioral change for the conditions they're managing. So primary care is one. An example would be, I need you to quit smoking. Or adolescent medicine. You're trying to get a teenager, God help you, to do something, right? Or not do something, whatever. A lot of those areas have taken cues from certainly psychology, psychiatry, but even marketing and a few other things where they're in the business of human psychology and what motivates and demotivates people. Yeah. So my brother is a general pediatrician, and he does a lot of his practice is teenagers. And so he has to like convince them, like, don't smoke so much weed, or, don't drink, or
stay off your phone.
Yeah, quit the promiscuity, you're going to get in trouble. And that's just not going to work for a teenager. So what you have to do is deploy what's now called motivational interviewing. And this has become a discipline. I'm sure it's in other industries, but it's become more prominent in medicine. But it's motivational interviewing where it's, let's pretend you're a smoker. And we do this already. I'm like, well, James, I know you've been smoking. Last time you told me you smoked a pack a day. How's it going? Are you still smoking? Yeah, I'm still smoking.
I'm up to 2.
Yeah. Well, but and they get into the satisfying vices. Yeah, but a pack takes me like a couple of days now to get through. And so then part of it is, that's great. Like you start off with like, that's great. Because it truly
recognize the success.
Like you've done a great job.
Yeah.
That's fantastic. You dropped it by half. That's huge. I said, where are you on the scale of 1 to 10 in terms of like 1, there's no way I'm going to quit smoking, and 10, like I'm throwing away the cigarettes right now. And you'd say, pick a number. You'd be like, I'm 4. You're like, great. Why are you not 2? And they're like, well, I don't know. I know smoking isn't good for me. I'm like, oh, I agree. Why do you think that is? And the whole technique is like, minimize my talking and make the patient put in words why they should do what they want to do. Really, what about smoking is bad? Well, I know it gives me lung disease. Oh, my granddaddy had lung cancer and he died. It was terrible. I'm like, yeah, that sounds awful. I'm sure you wouldn't want that. No, and it's in my clothes and I smell like hell and I have to do laundry a lot. And then, sure enough, you are moving yourself to the I'm going to quit. Because and the fact of the matter is, like I see you, I'm going to see you like 0.1% of your time. You are with you 99.9% of your time, right? And so what you're going to do when it's time for you to like pick up or not pick up that cigarette is going to be based on what's going on here. And so can we start to facilitate ways to help you? Yeah. Right? The old Jerry Maguire, help me help you. Yeah. But it's like, he told me that. I'm like, a lot of my world, preventative cardiology, same thing. Like I have to convince you, like, stay at a normal weight, don't smoke, manage your medical conditions, get off the couch. Yeah. So
we were just talking earlier today about like you're never going to, in our world, you're never going to convince someone to care about estimating their stories by telling them they need to use Fibonacci points. It's like, but why? What's in it for me? That discussion. Like the actual pain they're feeling. What happens when you roll a story over? What happens when you miss another delivery, et cetera? And it makes total sense. I mean, the most powerful conversations I have with a Scrum team is when they're talking themselves into it.
That's the thing. And that's something that it's a newer revelation to me, and I'm still bad at it. I know the mantra, like they need to know the why.
Yeah.
Like I've gotten that beat into me. But I find I'm the one who's still telling them, like, this is why it matters to you.
Yeah.
And I'm like, you're not quite there.
Uh-huh.
They need to tell you why it matters to them.
Not quite Socratic yet. Yeah.
I find myself referring back to that paragon of art called My 600-Pound Life.
Really is the pinnacle.
We have our coaching discussions, and there's this line that it was with a therapist talking to one of the subjects of the whatever episode I was watching, who made the comment, "I can't want this more than you do."
Yeah.
And that I think that's exactly what we're talking about. She just said the thing that you're talking about rolls around in the doctor's head as a means to figure out what question can I ask so that you can make it matter more to you.
Yeah.
Do you find? I find the times where I'm successful in a practice like that, where I get them to care about it more than I do, I find I know it's working when they come find me and tell me, like in a week or two. And they get that, like, "Are you proud of me?" moment where it's like, James, we were in a refinement session and we did the thing you were telling us about, and I think we did it well. Do you find patients coming back to give you that success story?
Yeah, absolutely. And I think they're profoundly proud, right? But before I don't have a clinic now, which I miss, but when I did before I got here. There was a woman who was a smoker, middle-aged smoker, a couple of other issues, but obviously needed to quit smoking for all the reasons she needed to quit. And I would do what I always did. I'm like, "Are you smoking? Yeah. Have you thought about quitting? Yeah." I'm like, "All right, well, think about it." And that was it. Yeah.
Checked.
Right. But at least I would say it. And, I remember people like, "You should always ask. You should always, remind them." I'm like, "Yeah, I'll do it." It never effing works. Fine, I'll just do it. And so then she had her visit, and then she came back whenever she came back 3-6 months later. And I said, "So how much are you smoking?" She goes, "I quit." "You did? Fantastic. Like, that's awesome. When did you quit?" "Well, when you told me." Are you fucking kidding me? Nobody listens to me. She goes, "Yeah, you told me." And then she said, and I didn't quite absorb the lesson, but as I've learned more, I did. She's like, "I'd already been thinking about it. I just needed the reminder, and you happened to be the reminder."
Yeah.
And I was like, that is why you keep saying this, because you will never know when it hits.
Yeah.
You'll never know.
Right time.
Just shots on goal, right? And it could fall. So so it's been an education. I feel like now, in my early 50s, like I would actually go back to the Bedside Manor class and be rapt.
Yeah.
And have many questions.
Yeah.
In some ways, I feel like I was too damn young to really understand the value of that course.
Right. You don't have the 100 patient experiences for it to stick to.
Very loaded question. Is there something you could have told 26-year-old you in his words to get him to, like,
that's a
you really
question.
should pay attention to this? And he says, "Okay, because that wise man told me that, I'm going to pay attention."
Yeah.
That's a great question. I'm not sure I'll have an awesome answer in seconds, but I don't know. I guess, I don't know if this is true, but I do wonder that if there was a stronger case made that I could hear of linking the fact that by this technique is as important, if not more important, than any pill you could prescribe or surgical procedure you could do to ultimately impacting that patient's health. I'm not even sure if I could have heard that or put it together, but if I could somehow have had that communicated and have it elevated to the level of therapeutic medical intervention.
Yeah.
I wonder if that would have been a productive way to do it. Because that's what I was interested in doing. Like, I was there for good reasons. Like, I wanted to help people. You know, like, this is one of the core ways you do it. Maybe that would have been it.
It's also a matter of when. Maybe in the midst of all of those other classes, maybe that's not the time. Maybe there's another moment to spend more time on it, because you're trying to
what's the
load a whole
Krebs
bunch of
cycle?
technical information into your head and then take a test to get a good grade on it.
Yes.
There's this forced hierarchy of what you need to learn.
Well, and to your point, so I went to med school at Emory University in Atlanta, and every med school does it a little bit differently. But at the time, not many med schools are set up this way anymore. But at the time, your first 2 years were all classroom, and you learned pathology and pathophysiology and all this stuff. And then your second 2 years were all clinical. You were in the hospital and clinics and learning the practice of medicine. But in those first 2 years, and the first 2 years is when we had the bedside manner. So in some ways, like, it's all theoretical. Like, we're not seeing patients. So that's part of the problem, probably, now that I think about it. The second is the way that they organized it is we had maybe 5, 6 classes at a time. And the way they would test is every 6 weeks, they would give one giant test. They called it the joint. And it was the joint exam. So you would be tested on all 6 subjects in one big, one-day test.
Wow.
I mean, it was just like fascinating culture that would develop because of 6-week intervals. So you would have 2 weeks of decompressing from your prior joint exam, 2 weeks of starting to ramp up, and then 2 weeks of absolute fucking panic. I don't know if we can cuss or not.
Go for
it. But, you know, and then you're just cramming day in, day out. And then you take the big test, and then you like go out and get hammered and rinse and repeat.
Forget it all.
Yeah.
It's a really good system.
There's a reason we've walked away from this. But I will say that when one of the classes was Bedside Manor, we're like, sweet, we're at this part of the exam. It's a nothing.
Yeah.
You know, so it was, there were many signals we got that this didn't matter.
Yes. Okay.
So I keep thinking about the segment in our Agile Fundamentals Bootcamp. We talk about empirical process control using VUCA. We play a game called the Spaghetti Tower. I don't know if you've seen that.
I've seen that.
And the mic drop moment at the end of it is you've spent your whole life trying to find the right answer and being graded on finding the correct answer. And in reality, the correct answer isn't always obvious, and you actually have to experiment, you have to get feedback, and yada yada yada.
Yeah.
I wonder if the message for typically grades obsessed, high marks students would be, if you want to find the right answer, this Bedside Manor is a huge piece of it.
Yeah.
More than anything, more than actually finding the right immediate medical answer.
That's right. There's several iconic figures in medicine. One of them was William Osler, who was a physician. He was one of the founders of Johns Hopkins, which obviously is one of the oldest med schools and a paragon in medical education. And he said, he's got several just great quotes, but one of them was, listen to the patient, they'll tell you the diagnosis. And it's totally true. We'll be befuddled, and then typically it's the med student who has a little bit more time, but also has almost the blessing of innocence. And as long as they're talkative and inquisitive, and a lot of them are, they go in and they'll pull out that salient detail that would come up in house. We're like, oh, that's the thing.
Oh, you
right?
raise pigeons.
Yes, you have a pigeon. They're like, oh my God, that's what it is. And we will be just churning through our rote, half listening interview. We would have missed all of it. And the patient knows, but you've got to be able to ask the questions, because we obviously have to connect it to our medical knowledge.
Yeah.
So
I'm so glad you brought up house, because this has been in the back of my head since you brought it up. So your assessment of house is that it's not realistic, because you said at the 1 minute he's prescribing some sort of chemo treatment, and then
when we're doing neurosurgery, delivering a baby.
Well, in the tech world, we would be like, that's a full stack developer.
Right.
That's great. That's exactly what we want.
Right.
So how do you, again, I'm trying to figure out how to reconcile these two.
So this is where my product team Kool-Aid kicks in.
Okay.
I've got a great, you just pulled together a couple of threads I hadn't thought about. All right, so let's set it up a little bit. So I'm laughing about the house example because, of course, a neurosurgeon isn't going to be the one to deliver a baby.
Right.
And, of course, an obstetrician isn't going to be delivering chemo, right? And that would be crazy to do that. And the reason they do it on TV is they just want you to understand the 6 characters and follow them, right? So
And
I get it's a
hiring
device.
the other ones is expensive.
Yes, so I get the device. It's fine. It's obviously made up. But in the reality of the world, like what I learned from product is like, oh my God, handoffs are a total sin. Like, that's going to be terrible. But you do have to deal with the reality that, you know, for a very complex technical solution, you need a lot of deep knowledge that just can't live in a single brain. Like, you're going to need a team.
Mm-hmm.
But the cross-functional team and just sort of giving them the environment, the ceremonies, the artifacts, everything part of Agile, to work together effectively and harness the knowledge that lives in each of the individual brains, I think has a lot of power in a variety of industries, including medicine. And the example I have is we are siloed all the time in medicine. Like, I'll live in my cardiology world and I'll throw shade on the nephrology world or the oncology world. I've been throwing plenty of shade on the surgeons, right? Like, we do this all the time, and it's partly tongue in cheek, but there's a little bit to it, right? And it's siloed. And I think one of our challenges and what we've experimented with in the Innovation Lab, and I think is a really exciting area of inquiry, is how can you start to build moments of cross-functional collaboration that allow us to fully leverage the talent in that team live, because that's really where it works. And I had it accidentally illustrated. This happened like 4 years ago, and it's burned into my brain. So I've mentioned that one of the ways I practice is I do this consultative service. So somebody comes into the hospital for a non-cardiac issue but develops a cardiac issue. So then the treating team will call me and our team and say, hey, come help us out, as long as the patient needs your help from a cardiac point of view. So an example is, if people need a surgery, like an emergent surgery, and they have underlying cardiac disease, AFib, heart failure, whatever, often what they'll do is call us and say, hey, I need a preoperative consult, just to make sure the heart's good, strong as possible to get through the surgery, and we're not going to run into problems. Great. We do that all the time. One morning I go in, and we work with house staff, so my fellow is the front line. They get all the calls. And I walk in, the fellow's like, hey, I just got a quick call from the pre-op holding area. There's a guy, he has heart failure, a defibrillator, several other cardiac issues. He fell this morning, broke his hip, and they need to repair it emergently. But they're worried because he's got like a list of cardiac issues, and they want our opinion before he goes under anesthesia and they get to work on the hip. I'm like, great, let's just, we're like nearby, let's just swing by before we go round on the rest of the people we know about. So we swing down to the pre-op area, and just out of total serendipity, I arrive at the bedside at the exact same time that the surgeon is there, the anesthesiologist is there, and this guy had a defibrillator. The device specialist who manages defibrillators was there, like next door, like he was literally in earshot. He's like, oh, you need some help? So everybody all of a sudden is now literally a cross-functional team, is surrounding the guy.
The patient.
Exactly. And some nurses, and there's probably like 6 people around there. And so the surgeon's like, who are you? I'm like, I'm Tom with cardiac team. Who are you? I'm like, oh, I'm the orthopod. I'm like, oh, great. Who are you? I'm the, so everybody like got introduced. We're like, oh, we got everybody here. Holy shit. I'm like, so what's the deal? And they're like, well, so we need to repair the hip. I'm like, got it. What are you worried about? They're like, well, I'm worried because is his heart strong enough, and what's going to happen with the defibrillator? Because we use electrical-based tools during the surgery, and that's always a worry. Like, will that do something to the circuitry of his defibrillator? And the device goes, well, let's talk about it. Like, this is a generation he has. I'm like, yeah, tell me, like, in surgery, like, what exactly are you using and when? He's like, well, we don't use it's a Bovie, it's a cauterizer tool. We only use it at this part of the surgery. And the device guy's like, yeah, well, that's only going to be a problem there. And how far away are you? Well, I'm here. Well, develop. Okay. Well, then you don't have to worry about it in this way. So at this point in the procedure, there are things you can do to monitor the defibrillator. So just monitor it at that point. The anesthesiologist's like, oh yeah, I know when you do that. I'll do that. And I'm like, well, why does that matter? So the orthopod taught me a little bit about the implant. The device guy taught me a little bit about the device. I learned something from anesthesia. They learned from me about various cardiac issues. And we got done, and we had a plan that was like exquisitely dialed in to what this patient needed when everybody knew their role, everybody knew what was next, everybody was focused on the outcome of getting this guy a new hip while getting through it from a cardiac point of view from a good, in a good state. And we got done, and that patient was like, this was amazing.
Yeah.
He's like, thank you all. Like, this is incredible.
Yeah.
And
That
it
should
really
be
was,
that
I was
should
just,
be the BJC commercial.
and I'm just like, but it never happens.
That's not a normal
And
experience.
if everybody wasn't
Never
there,
happens.
how long would it? There wouldn't
No,
been a plan.
I would have written a note that would have been kind of a shitty note because we're quick and we're moving fast. They would have written a note. It wouldn't have made sense. Maybe we would have read it and things would have happened and it probably would have been fine. But it could be even better, both from an outcome and an experience point of view.
Yeah.
Like, how much better did that patient feel?
Yeah.
Right?
Mm-hmm.
Like they were cared for
Yeah.
in a very, very personalized and deep way. And so what we've wondered is how can we start to facilitate that? And to your point, it's like technical expertise, but then the human interaction that occurs not only with the patient, but amongst the providers. Because frankly, it gave me a lot more enjoyment. Like I loved that day. I learned a lot. And that was like, it was
Yeah.
kind of inspiring. It was stimulating intellectually. Like I walked home and told my wife, I'm like, oh, I learned all this stuff. And so
So you
I
were more
think
engaged
like
because
I'm
of it.
engaged. So now I'm more excited about work.
Yeah.
It's just a virtuous cycle.
Yeah.
So we've talked about, can you start to think about virtual technologies or other ways where you have a stand-up, you have a scrum around, I don't know always these words, but you have something around these issues.
It seems like, I guess I'm dumb for thinking patients on the bed there getting ready for a procedure.
Yeah.
Whatever.
Yeah.
I assumed all the doctors involved with all those specialties at some point got together and talked about that.
Ideally.
Okay.
But the reality is it's just really hard.
You get 2 out of 3, you get 3 out of 5.
Yeah, and timing is something, and we don't intentionally coordinate it. And some places do. I've been at other hospitals where it's a little more intentional, and I think we should move towards that. For whatever reason, WashU hasn't quite done that. But and there's plenty of systems that don't do
Sure.
it. So I think it should become a lot more standard in the way we deliver care.
You use the word consult. And generally what I pick up on in this conversation and in other conversations with medical professionals is that the precision of the words.
Okay.
And that, I don't even know if you recognize when you talk about a consult that we don't have consults. I don't know what that is. What constitutes a consult?
So I think it's an artifact of the sort of team structure in a hospital setting. So when you come into the hospital, you are assigned a service and you have one attending physician. And that physician is legally responsible for everything that happens to you in the hospital.
Okay.
Typically, like in today's world, that if it's a medical condition as opposed to a surgical condition, that typically is a hospitalist. So somebody trained in hospital medicine.
Okay.
They're the analog of a primary care doc in the ambulatory setting, but they only practice in a hospital. So they're experienced in dealing with most of the common conditions that come into a medical floor on the hospital.
Okay.
Renal failure, pneumonia, heart attacks, whatever. And then they're trained as a general internal medicine doc.
Okay.
So they have good knowledge in most of the organ systems. But when it starts to get complex, and they need specialized knowledge about the heart or the lungs or the kidney or whatever, they will, as we say, call a consult. I'm calling a consultant who's generally a specialist that can opine and help with whatever very sort of specific question you have. And we tend to be organized by organ, by and large.
Yeah.
And so I serve as a consultant to that team for that issue.
So a couple things that come to mind. First of all, Conway's Law. The architecture of your system is a mirror of the architecture of the organization. So the way that your software is designed and architected
Yeah.
generally going to look like your org chart.
Oh, interesting.
Yeah.
Yeah.
But so when you say we're organized by organ,
Yeah.
well, that's Conway's law.
Yeah.
Because that's what you're working on is the human body,
Yeah.
which is comprised of organs. Oh, that was interesting. The other thing is,
But it promotes, and I assume Conway's, there's probably a corollary of Conway's, like you then start to think about your role in an organ-based way.
yeah.
Do you think of yourself as a heart or a lung?
Yeah, right.
Right? No.
Yeah.
And in many ways, like healthcare and caring for the patient requires a whole patient approach,
Yeah. Uh-huh.
which is sort of at cross purposes with
Yeah.
an organ-based approach.
Yeah. The issue is that there's no the corollary there. I think is if you need to re-architect your system, you're not going to do it unless you re-architect your org chart.
Mm-hmm.
But we're not re-architecting the human body. We're, the heart pumps blood, and it will always pump blood.
No, correct. But if your unit of organization is an organ, is that really the right way to manage a whole person's health?
Yeah.
So
Right?
I'll common sense check me here. I was listening to a podcast last weekend, and this guy was talking about the influx of chronic diseases and how typically once you get one chronic disease, you get more and more, and those diseases go to specialists, and they start to get managed in silos.
Correct.
And
That's the problem.
I'm going to use the diabetes doctor cares about managing the diabetes,
Yeah.
right? The gout doctor cares about managing the gout. The brain fog cares about the brain fog.
Yeah.
No one in the world he's describing is stepping back and saying like, why is this person getting more and more unhealthy?
Yes.
And look, they're 70 pounds overweight. What
Yes.
if we started to
Yes.
ramp that back? And all these specialists are trying really hard, and they are therefore sub-optimizing the system, which is the human body in this
Mhm.
case, in order to optimize their own piece of it.
Correct.
Is that happening regularly? And
All the time.
if so, I think that's the switch to flip there, is the definition of success isn't really good heart outcomes or really good diabetes outcomes. Yeah. It's root cause analysis with patient outcomes.
Yes. Going back to your GP experience and how you don't like it, I think, and this has been an ongoing issue for medicine for decades, like how do we organize ourselves to deliver optimal health to patients? Yeah. That's the core mission, right? And for a long time, we thought, back in the HMO world in the 90s, we're like, the primary care doc will be the quarterback of your care. Yeah. And they'll be the gatekeeper. And that engendered all kinds of hell because people are like, well, I want to go to my specialist, and there's choice and autonomy issues. Part of the problem, though, is medicine has become so complex, and it's becoming even more so. Not only like, maybe the conditions are semi-straightforward, but the therapies we have are just dizzyingly complex now. Oncology is a great example. Like, I can't even recognize the kinds of therapies we now have for cancer compared to when I was training. There's been such a explosion. And even in my world, like I was giving a lecture earlier today to some of our NPs on heart failure therapies, there's a massive armamentarium. And you've got to understand all of that. So it is now unrealistic to expect one person, a primary care doctor, whomever, to be able to manage all that effectively. The challenge remains, though, that if you just outsource it to a bunch of consultants like me, yes, I'm going to optimize what I know how to optimize. Yeah. And we try to think holistically. We're trained in medicine, and we are obviously oriented to whole body health. But at the end of the day, that's what I do. And so we're gonna naturally favor things that
a surgeon wants to cut.
Surgeon wants to cut. I want to manage the cardiac conditions. I'll think less about the other comorbidities. And I don't know. I don't know what the right answer is. There's no one right answer. But I think
it's not simple. The right answer isn't simple.
It's not at all simple. People are getting sicker. We are enjoying the fruits of our success in healthcare by people are getting older. We've never lived longer than we have now. But the fact of the matter is we're also never sicker. You're spending longer periods of time sicker than we ever have in human history. Success?
That was
but it's a moving target. I mean, the human body is a complex entity,
sure.
But it's becoming more complex based on the new chemicals that we're adding to it, and the chemicals that agricultural industrial machine is feeding into it.
We also have a bias towards action.
Yeah.
And the sins of omission are much worse in medicine than the sins of commission.
What do you mean?
So the sort of overall culture is, if you have to make a decision between doing something or not doing something, do it.
Wow.
And if something happens, a side effect or a complication or a problem because you did it, the sins of that are far less than the omission.
Interesting.
So typically, like if we say, hey, I advise that you get this pill, I advise that you get this surgery, whatever, and something bad happens, almost always the patient's like, doc, you tried.
Yeah. Yep.
But, I mean, think about what's in that statement, right?
So it
Doc,
is.
you tried.
It is incentivized for. You would rather a patient leave you having told them to change something or to add something.
Yes,
versus
that I did something.
versus let it coast.
Well, what if you came to me and you said, I'm having this issue, and I'm like, the best strategy is for me to not do anything. I think, despite your best
That
efforts,
feels weird.
you'd feel like, why'd I come here?
Yeah.
Right? It's just a psychological setup. And I feel the same way. I'm like, why am I here? Why did I take your copay?
Yeah.
That sucks. And then our reimbursement structure incents activity.
Yeah.
So it's not like you're driven by money, but there's no break to it. And so, it's more.
Yeah.
It's like those generative AI sort of memes right now.
It just keeps going.
More.
There's such an overlap in the concerns and the things that we're trying to solve here, because just like all of those added layers creating more complexity and just trying to treat this human being, we're getting to the point where the software. I mean, Noah Harari in Homo Deus talks about how there's not one individual who understands how the Google algorithm works.
Right.
It takes, and everybody's kind of got their piece, and together it somehow works.
Yeah.
That's becoming more and more of a thing across all new technologies that we're building. I think we're running up against the limits of that full stack developer, that generalist, that we hope we can maintain, who can get us from concept to cash, and just fix this thing over here, fix this thing over here. The layers required in technology now, in order to get a feature out the door or to support technology in production, too vast, too interdependent, too detailed in their scope, that you can't ask one individual to just keep all of those ideas in their brain.
So you guys are in the same evolution path that medicine is.
Yeah.
The idea of a primary care technologist is probably becoming defunct.
Right.
Your IT department can't be 3 people in the basement and they handle everything from your phones to your app support.
But so the question for us in technology is, given what you're describing as the situation where the cardiologist is caring for their area of expertise, whereas the oncologist is caring for their area of expertise. How can we avoid the downsides that have resulted, that we just described, in the world of technology?
Well, there's no solution. That's why it was so resonant for me to learn about the product model and cross-functional teams, and why that example I gave for the preoperative evaluation, to me, was so powerful.
Yeah.
Now, how you do it is complex, and I don't know what the answer is. But facilitating those kinds of interactions, where the reality is the knowledge has to be distributed across multiple brains. The subject is too complex, whether or not it's technology or medicine.
Yeah.
There's no way out of that. And that's okay. But how can you then pull together and provide sort of an emergent, intelligent team that can act with the combined intelligence of that group in a helpful way? And so whether you do it with Scrum or whatever in the tech world, or if we do it with multi-consult rounding in the hospital, or however we organize ourselves, I think it feels like the right direction.
I think that was the fade out move. That was awesome.
Good. That was really cool. I can talk about this shit for hours.
What did you get? What did you like?
I mean, I felt like we could have gone another 3 hours without issue.
3 days.
This is by far, and I told him this is the longest conversation I'd ever had with a doctor before. And it makes me really wish every interaction with a doctor was like that, because there's just so much knowledge to be gained. For me, the most interesting part was the spontaneous cross-functional team story about the group of specialists that all came together. And really resonated with me when I first met my wife. She was working through an autoimmune diagnosis, and it was specialist to specialist to specialist, and she'd been going around the circle with them for 3 or 4 years at that point, trying to figure out what was going on. And I came in and like, could you just get them on a conference call? Because that's my world. Right. And sure enough, we just 3-way called with specialists and cut out 6, I don't even know how long, in the process.
So you were able to do that?
Yeah. We just scheduled it and got everyone on the phone all at the same time. And it's still shocking to me today that that's not just common practice, but the double-edged sword of specialization really kept coming up in this conversation. Yeah. You need specialists, but they can't be in silos away from each other.
Yeah. I've been thinking about affable, accessible, and able since the conversation, but upon re-listening, the part that got me the most was in order. In this order.
Yeah.
Affable, accessible, able.
Yeah.
I have a feeling that's going to show up in a consulting engagement or a training session at some point in the near future.
Agreed.
Well, I'm glad you joined us for this episode of Raise the Bar. We've got another episode coming up for you very shortly, which I'm sure you will enjoy just as much as this one. And if you did enjoy this one, I'm just going to ask you to whisper sweet nothings into the ear of that like button and just gently caress it, and then punch it hard.
What are we doing with the subscribe button?
Oh yeah, the subscribe button. Yeah, don't let the like button know what you're doing. But if you could give an equal amount of love and attention to that subscribe button, we'd appreciate that too.
Enjoy.
Yeah.